east and west. Will you give me, am I on? All right. Okay, can everybody hear me? Excellent. All right. Well, I could say good evening if I was in Australia, or maybe, good night. But anyway, it's obviously good afternoon and good morning here at ESC 2023. Today, we're here to talk about prioritising the cholesterol management in cardiovascular disease patients, which, as we know, is all incredibly important. And even though we talk about a lot of new therapies and a lot of new drugs, it's key for our patients that we actually implement what we know about cholesterol and cholesterol management into the treatment and care of our patients. So we're here to talk about the World Heart Federation roadmap for cholesterol management in cardiovascular health policies. And I'd like to say thank you to Amgen, our sponsor, for today. So I'll first quickly introduce our speakers. Mr. Neil Johnson, who's from Ireland and CEO at Crony West of Ireland Cardiac and Stroke Foundation and National Institute for Prevention and Cardiovascular Health, and also the Executive Director of the Global Health Hub. Welcome. Dr. Rahul Santos, co-chair of the World Heart Federation Roadmap on Cholesterol for the 2022 update and the director of the Lipid Clinic at the Heart Institute in Cor, and associate professor of the University of Sao Paulo in Brazil. And Professor Paul Dendal from Belgium, the closest person I think that has travelled here today, president of the European Association of Preventive Cardiology. So we've got a few questions to chat about today, if that's all right. If it's okay, we'll start with you, Neil, to start with talking about the Global Heart Hub. It recently launched the Global Cholesterol Action Plan, I understand, to reduce the impact of unhealthy cholesterol levels. Do you think you can provide a little bit of an overview and also perhaps describe how it can complement the World Heart Federation roadmap?
Yeah, so firstly, by way of introduction to the Global Heart Hub, it's, I believe, the first international alliance of heart patient organizations. Launched officially in 2019. We have, I think it's about 105 patient organization affiliates right now. And what we're trying to do here is to unite the community in a way that hasn't been done before, those with lived experience, and to give them a voice. And no better a topic to have a voice on than cholesterol. It's very clear that cholesterol is a main driver of heart attack and stroke, which, as we know, is the biggest cause of death and disability across the world. And I think there is a consensus among the patient community, particularly those that are affected by a cardiac event, that as a society, all aspects of society, we've become far too complacent when it comes to the issue of cholesterol management. So the Cholesterol Action Plan is in effect a ground-up initiative fully aligned with the World Heart Federation roadmap. And basically, it's calling for civil society to join with medical societies and others in a united call to action at national policy level, where really it needs to be a bottom-down approach in terms of seriously looking at how we detect, manage, and treat cholesterol. So in its simplest format, it's about joining forces and really articulating what the World Heart Federation roadmap has outlined.
Fantastic. So it sounds like you think it's completely aligned, it's going to help each other. And maybe if there are people here from other global organizations, how can you envision that they might connect?
Well, at this early stage, the action plan has only recently been launched, and a key objective is to create alliances. So we all need to work together. At the European level, for example, Global Heart Hub is part of the EACH initiative. And as people probably know, this is an attempt to bring cardiovascular health to the fore in European health policy. In the same way as there is a cancer action plan, there needs to be a cardiovascular plan, and of course cholesterol will be part of that.
And you bring out an important point. I mean, how these alliances can actually help each other to strengthen policy or change policy, isn't it?
we need a complete paradigm shift in terms of public mindset on cholesterol. I have just literally, so why I'm late, I apologize for this. I've just been at a presentation of a study of 27 countries looking at cholesterol and BP management. And one of the fascinating things that came out of this morning's presentation is issues like, for example, what the physician's perception of control is and what actual control is. And the discrepancy is enormous. So, and that's just one area, for example, where, again, you have to question, why is that?
Well, that's a good point to ask Rahul a little bit about the World Heart Federation roadmap on cholesterol and how it is talking to implementation or its challenges.
It's a real privilege to be here, and actually the whole roadmap thing is really try to bring the best of we have regarding science and try to translate that into something that is easy to do and can make a lot of difference for the lives of our patients. Basically, I think this is how it is. As been said, cholesterol probably killed 3.9 million people in 2017. That's the estimation that we have. And I can guarantee you that most of these lives could have been saved if we had an adequate diagnosis and an adequate therapy. And actually, we have probably one of the most robust evidences in science on this association, causal association. And now we have very, let's say, robust, safe, and inexpensive therapies to cope with inadequate levels of cholesterol. And I think there's a huge shift on the paradigm, because we now know that actually most of us here have inadequate levels of cholesterol, and actually the cholesterol should be treated. Not necessarily medications, but we start very early with the adequate lifestyles. But actually in people who have, let's say, other risk factors in association with inadequate cholesterol levels, definitely pharmacological therapy that is very inexpensive and safe can make a lot of difference. Unfortunately, actually most people who need to be treated are not even recognized that they need to be treated, are unaware that they need to be treated, and actually those who already have a high risk of events and are supposed to be taking their drugs or being adequately treated are not. So we identified huge gaps on the therapy. And actually when we came with this thing of the roadmap, was not only to really bring the epidemiology and the science on everything, but also identifying the roadblocks. So, and theory is one thing, clinical practice is something totally different. And definitely we really tried to bring on this document what we understood, and actually we made a survey with the World Heart Federation members from all over the world, and actually tried to understand what was going on in these countries and why cholesterol was not identified, treated adequately. And actually we came with many, let's say, issues that could help us really try to trespass these roadblocks and make things flow in a more efficient way. And definitely, I think we have an idea of what needs to be done. Of course, the world is very heterogeneous, and countries are very different, the systems are very different, and the World Heart Federation needs to work with its partners to really understand what's going on, and really try to bring out this beautiful thing that we really put together on the roadmap, and try to change the reality in different places. You know, this is how I see it.
Yeah, no, look, that's great overview, Rahul. I mean, you talk about working with a heterogeneous world. Perhaps you can describe some case studies or some examples of how the roadmap has already been implemented or may already have influenced places around the world.
You know, actually the World Heart Federation has been working with, made some meetings with local societies with this stuff in Colombia, in Portugal, in Asia, and really try to understand the local realities and try to see how we could implement the recommendations No, because what happens is that despite the fact that physicians are the same, the guidelines are the same, we have physicians may see things differently, and we might find ways of really coping with these differences and bringing the adequate information to make things work, you know. So, of course, there are different examples on different countries on how things are, and should be very specific. But what we're doing is to really getting together with these colleagues and try to understand their realities. They can bring their roadblocks, and we can discuss together the possibilities of trespassing the roadblocks. This is how I see it. And of course, in my opinion, we have different barriers. One of the biggest ones is literacy about cholesterol, not only for healthcare practitioners but also for people overall. And also we have so many, you know, bad things being said about the association of cholesterol with cardiovascular disease, the safety of the therapies, the importance of reducing cholesterol, and definitely we must finding ways of bringing the correct information for the population in order to trespass these barriers. And on the other hand, we have issues regarding the systems, for instance, lack of availability of the more adequate therapies, lack of availability of how to monitor cholesterol. And this is something that, of course, depends on each reality. But we must identify each local one and try to trespass this. And I think the World Heart Federation, working with the local societies, can make a lot of difference for all of us.
So you've talked about how, you know, you could go to each country to actually customize the roadmap for each country's experience. And, you know, obviously there's a lot of countries to go to, but the World Heart Federation is keen and committed to doing this because it's important, right, for everybody. Maybe just bring you out a little bit about familial hypercholesterolemia and what sort of things that the roadmap talks to about FH.
Yeah, definitely two of the main focuses that we have in the roadmap. One is people who already have cardiovascular disease, who are at a high risk of having events and dying because of that. And the other one is FH, right? FH actually is the disease that I work more. So I run a lipid clinic. I have more than 900 patients in my clinic with this disease. And actually it's a very frequent disease. 1 in 300 people are affected by FH. And actually within the families is 1 in 2. And this disease, actually, the problem with that is that you're born with high cholesterol, and you get coronary heart disease probably 10 to 15 years earlier than the usual population, and the risk of dying of that is probably twofold greater in people with FH in comparison with people without FH. And the good news about FH is that if you start early therapy, you can normalize people's lives on that. They will live exactly the same amount of years that everyone would live, right? And nowadays it's amazing because we have such amazing therapies for FH. Not only the statins, the ezetimibe, but the PCSK9 inhibitors can really normalize cholesterol of people with FH. But what happens is that the disease is highly underdiagnosed, severely undertreated, and most people with FH have no idea that they have it. And definitely we must increase awareness of FH. We must increase awareness of the cascade screening to find people with FH. And definitely we must provide ways of access to the newer therapies that can make a lot of difference for people with FH.
So, I mean, you've spoken strongly to how, you know, FH is treatable, right? Like, you can make a huge difference if you actually identify and treat it. But it sounds like, you know, a lot of people don't even know that it's a thing, or don't even know how important it is. What are a couple of things that you might want to message people about with respect to how we as a clinical community might increase awareness around FH? Because, I mean, clinicians and you know, aren't necessarily that role. Whose role is that to raise awareness in communities about FH?
You know, I think there's a disease that cholesterol has a lot to do with bad things is FH, right? Because you're born with high cholesterol, and because you're exposed to very high cholesterol since very early, you run a greater risk of developing coronary heart disease very early. And this is a frequent disease, right? So it's 1 in 300, but if you go to the coronary care unit, probably 1 in 17 or 20 will have FH, especially if you're young. And what happens is that, okay, physicians may diagnose someone with high cholesterol and suspect about FH, but what happens is that they don't check the families. And I think the first thing is, okay, check the families. So easy, don't need to do a genetic test, just do the cholesterol, okay? Okay, if you have genetic testing, it's great, it's better, but simple, inexpensive, and actually you can start an inexpensive therapy that has been proven to be very safe, even for children, and can make a lot of difference for the population. Now, of course, if you have more severe FH, PCSK9 inhibitors will be necessary because now you can normalize cholesterol, something that we thought we never would be able to do in the past. We can normalize, and we can save lives with that. So increase awareness, start early therapy. These therapies are safe, and they can make a lot of difference.
The importance of cascade screening, right? I mean, it's...
No, definitely. You come from Australia, right? So
Yeah,
Australia,
I
have a very good friend there, Gerald Watts, right?
Yeah.
And actually, cascade screening can make a lot of difference. Can make a lot of difference, and definitely must check. We must, you know, I was very upset that the U.S. Service Prevention Task Force just said, oh, we don't have evidence for checking children for high cholesterol. Come on. Every adult with FH was once a child with FH. And it isn't expensive, you know, when we think about the amount of money that we expend with health. Come on, just check cholesterol. Very easy.
Yeah.
And we can make a lot of difference for these families.
I mean, some people do ask me, whose responsibility is it to ensure cascade screening occurs? Whose responsibility do you think it is?
No, you know, it's... okay, lipid specialists, but there's no rocket science for that. You know, a pediatrician and a GP can just order a cholesterol test and check that.
Yeah, please comment.
Just to come in on this and tie back to what I was speaking about earlier in terms of the action plan and the World Heart Federation roadmap, I think the science is there, as has been described. And what I think is now necessary is an unprecedented advocacy initiative at every country level. And so the World Heart Federation are providing their clinical societies with the science and the evidence. And I think it's important then that at national level, these clinical societies engage with all the other stakeholders. Because in the case of FH, for example, it is almost a scandal, actually, because this is the low-hanging fruit. These are individuals that are easy to find. You can treat them. And given the risk profile, this is where we can make an immediate impact very, very quickly. And there are some great examples of great initiatives. In Slovenia, for example, they now have a national screening program. They have detected 99% or 90-something% of FH.
Way to go, Slovenia.
In my country, in Ireland,
yeah.
Where we would estimate probably, well, certainly 90% of those with FH are not diagnosed. These are walking time bombs. We don't have a screening program. We don't have care pathways. We don't, you know, there's no plan. And those sort of plans need to come from the top down. It's not up to the clinicians. They will deliver, but ultimately you need policy.
Yeah.
And you need a health policy that prioritizes cardiovascular health.
Yeah.
And a clear issue in this is cholesterol.
Yeah. So Neil brought up a few other points there. One, it's a scandal, right? But two, you know, clinicians probably don't feel comfortable saying it's a scandal, but consumers and policy and the public recognizing it's a scandal and saying that
exactly, and that's why I think we really have to rethink as a society how we're looking at cardiovascular health, because in a strange way, the success of cardiology is its worst enemy. Because the advances have been so great that people now have a heart attack, they're on the table in 90 minutes, stented and home, and they think they're recovered.
Yep.
We know that ASCVD is a chronic condition, and that is not the perception in the general public. So we need to get that message out there.
Absolutely, and Paul, that's a good time to bring you in, I think, talking about the recent guidelines that have been, I suppose, introduced as updated, etc., recently here in Europe. Where do you think implementation is at with respect to those guidelines?
Well, thank you for this inconvenient question, Clara. As a past president of the European Association of Preventive Cardiology, I am not really proud to say that we're not doing well in preventive cardiology. And as you know, the World Health Organization some 8 or 10 years ago put forward the concept that if we can bring everybody towards a healthy lifestyle with a minimal risk profile, so no smoking, no obesity, enough physical exercise, good cholesterol, everything, that we would reduce by 80%, 80% cardiovascular disease and diabetes, and by 40% cancers. So I think there is an enormous opportunity here, and I think the ESC conference could be like 80% smaller, and we would need 80% less cardiologists if we would be able to do so. And if you look at the Euro-Aspire surveys, you know, the surveys are being done in all of Europe over, let's say, every 5 years. We see some slight progress in the concept of reducing risk factors in secondary prevention, in this case, which is indeed the low-hanging fruit apart from FH. But even there, we are not reaching our goals. We see some slight progress in the treatment of cholesterol. Of course, the targets are getting more and more stringent, so it's a bit more difficult than in the past, but still we have all the medication we need to do so. So it is really a pity to see that in smoking, in obesity, in inactivity, in diabetes, we're seeing opposite trends in some cases. We also see huge differences within Europe between East and West. You know, there are manifold increases in risk the more you go to the east in Europe. So it means that the structure of healthcare, the way physicians are treated, also the health literacy of patients differs, and this means that a lot of people are dying in the east of Europe and in many places in the world.
I mean, Paul, you've explained to us how transformational prevention or implementation of prevention could be. I mean, 80% reduction in cardiovascular disease is pretty out there, obviously. But I think you've started to allude to some of the, I suppose, poor outcomes we've seen so far in the implementation of prevention. And I think you've started to touch on some of the barriers. Can you summarize or speak to what you think might be the main barriers to implementation of prevention, and maybe particularly to cholesterol management?
Yeah, well, we should go at the different levels. And the question is always, what can we do, we as a person, as a healthcare provider? And so there are different levels where we can act. Of course, if you're sitting in front of your patient, then the idea is know your guidelines and test your cholesterol and make sure the patient reaches the goal. Once you are at the goal, the work is mainly done, because whenever you have an LDL cholesterol that is lower than the target, then this aspect is covered, and as long as the patient takes the medication, it's okay. So there is, from the side of the healthcare providers, there is some work to do. Know your numbers and make sure you use them for the patients. A second thing is for the patients themselves. I mean, when you are as a clinician, we tended in the past to say you should do this, and you should do that, and you should do that. And then patients go home and says yes, 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 and nothing happens. So what we need is shared decision making, because it differs. If you speak to a 20-year-old person with a cholesterol that is slightly elevated and no other risk factors, well, the approach is different from a secondary prevention patient. And so you need to know about sensitivities of the patient, why they don't take the statins. I mean, there is so much false information, and it's not by saying you should take this drug that things will change. So I think that's the level, interpersonal level, that we should act. And then, of course, and there the World Heart Federation has to play a role, like ESC has to play a role in the level above, policy. I mean, health policy should make it easier to do the right thing. I mean, for example, moving more is difficult in Brussels because taking your bike has a danger of accidents. So the government needs to make sure that there are bike lanes, that you can do your exercise as part of your normal life. Nutrition, the same thing. Healthy nutrition should be cheap. And cigarettes should be more expensive. So these are levels where governments can change something, and I'm really glad to say that the ESC, the Advocacy Committee, has managed now very recently to convince the leadership of the European Union to go for, we hope, a national or a European heart health plan. So if this really works out, then there will be enormous joint efforts at all levels to make sure that these healthy choices are made more easy.
Fantastic. I mean, you know, you've talked strongly to policy, and I've noticed a lot of bike lanes here, actually, locally. It's been great, actually, seeing bikes everywhere, though I do notice they're not wearing helmets, which I'm a little bit fascinated about. Somebody's going to have to tell me why they don't wear helmets, but they ride so much. It is always that sort of, you know, you brought up the question about what discourages people from physical activity and then what encourages people from physical activity, and sometimes it's doing, you know, all of the things in the same direction in terms of these sort of things.
I think, Clara, that this helmet idea is really there was a lot of discussion in Belgium because somebody fell off his bike and died, and then you said, okay, if that person had been wearing a helmet, it would be okay. So there's one approach is the government or the doctor saying you should wear your helmet and make it a law. Or you can do the shared decision making and say, okay, if I'm 75 years old and driving an electric bike and I'm not used to biking a lot, then I should wear a helmet. Or if I'm doing 40 kilometers an hour, I should wear a helmet. But if I need 10 minutes from my home to the hospital on bike and there is no car around, well, I think I can do it without a bike. So this kind of idea is that you should balance the risks with the outcomes. And that's also for prevention.
But I suppose I was speaking to the variation in some of that policy because, as I mentioned, I'm from Australia, and you wouldn't see anybody allowed to not wear a helmet. And, you know, there's a lot of cyclists, obviously, in Australia. I'll bring out one other point that I think Neil controversially said, that doctors are their own worst enemy in implementing prevention, because a lot of patients think they're saved after they've had their stent. And, you know, we know that it's only the start of that journey. Can you, you know, share some thoughts about how, I mean, you did talk about communication, but how we can raise that or change that dynamic for patients? We don't want to tell them, you know, to be too negative, but how can we share that message more broadly in the community?
Well, I think there are several ways, again, to approach this problem. I'm quite convinced that decision support systems in the future will help you in as a physician to at least know the numbers, know the rules, know the guidelines, because that's now a problem. There are 4 or 5 new guidelines coming out. If you want to read them once, you probably need 3-4 days. If you want to study them and know them, it's going to take you even more time to study it. So that's one thing that will help us in the future. I think also training physicians to really communicate with patients is also an aspect that is, we are doing that now at my university in Hasselt. We are putting more emphasis on that. We have a patient group that is participating in the education of young future physicians, and that way this sort of more horizontal communication with the people you are treating will help to make your advice more acceptable. In the end, it's the patient who will decide if he's taking or not his pills. We can prescribe them and then be surprised next time you see them 1 year later that their cholesterol hasn't lowered. Well, this means obviously they are not taking the pills you're prescribing. And so educating physicians already, and also primary care physicians, also to take into account the patient perspective, will change the outcome, I think.
Okay. I'm going to ask everybody to talk to some of the sort of more what they might think they'd really like to see with respect to changing the dial and implementation. But I'm also reminded that this is meant to be a chat amongst everybody here. So are there any questions yet at the moment, or anyone want to raise any comments? Yes, please. Go ahead, sir.
So still I think we forget the policy of fire and forget, and there is no need to follow the target, which is raising a few years back. So still we are concentrating on regular checkup to achieve the target.
Well, so the question was the concept of fire and forget. So prescribe the patient the right medication, then you don't have to think about it anymore. I think there is value in that, but there is also value in reviewing your patient from time to time. And of course, it depends on the severity of disease. Like a heart failure patient, you would like to see more regularly than a young person in primary prevention. I think, as I said in the beginning, what we need to do, especially in secondary prevention, is make sure that as soon as possible after hospitalization, all the drugs they need, all the protective drugs are in place. And so we are trying within our rehabilitation program to make sure we start, well, discharge the patient with the optimal medication. We think we check at 6 weeks if their blood pressure, cholesterol, sugar levels are okay, and we adapt the treatment at that moment so that when the 3-month rehabilitation program is over, you're sure that they are optimally treated. And then you could sort of forget your patient, and well, not all of them, I would say, but then you're sure that when they come back, it will be a routine checkup, and probably nothing needs to be changed. And I think I'm proud to say that in our institution, we often see patients back that don't need any change, and you could even see this as a sort of a quality parameter. If you have to change your medication every year you see the patient, then it means you probably weren't right in the first place. So I agree with you. Start with high-dose statins in all secondary prevention, for example, and then see if it's not enough, then go to stronger medication if available and reimbursed. And then you might think of forgetting your patient.
You know, one of the things that we emphasized on the roadmap actually was monitoring. Because what happens is that if the patients don't know their numbers, they might not be motivated to keep taking the drugs, right? And actually, okay, if I don't have the resources, fire and forget is okay as long as patient takes the medication, right? But we know that actually 50% of patients who take high-dose statins will not get more than 50% reductions in LDL cholesterol. So still, for half of the population, still will be a long way to go, right? And definitely, this is one of the roadblocks. Lack of monitoring facilities, ways of monitoring the patients. And this is something that definitely we must work and try to provide. And actually, I remember when we worked on not on this roadmap, but the last one, we already talked about point of care and facilitating things for poorer countries, poorer places, to really check cholesterol of our patients, because this is extremely important. And especially nowadays that we have other therapies beyond statins that could make the difference for those who really don't get there. So, and it's quite a challenge, and I think that has not only to deal with lack of adequate literacy from physicians and patients, but also we have, let's say, system barriers regarding availability of the therapies, of finding ways of seeing the patients, doing adequate risk stratification. So it's a challenge, but you know, in the end, it's not rocket science. It's not so it's easy to do if you have the resources, if you have adequate information.
Sure. So, I mean, you're speaking to the importance of monitoring, right? I mean, still measuring it is important to the patients, and so therefore we should encourage people to do it. So you wanted to make a point,
just on
Neil.
that topic, I suppose you're potentially alluding to the concept of physician inertia. So I'll ask a potential controversial question here, but before that, to state that clearly there's patient inertia as well, which is a very, very significant issue, and there's a huge piece of work to be done there. Challenges around literacy, of course, around how we educate patients to understand. I think, first of all, we need to educate the public to understand the value of cardiovascular health, full stop. and then to understand how to manage that. But in the context of potential clinician inertia, when you look at the data that shows, as I mentioned earlier, this huge discrepancy between clinicians' reported perception of their patients being at target and the actual being at target, does it beg the question, do all clinicians, physicians actually believe in the guidelines? Are there challenges there?
All right, who wants to have a go at that? Would you like to start off?
Yeah,
Ben?
well, regarding guidelines, of course, there is a process within ESC to make sure that they are as robust as possible, but they are human, of course. So you see in the gradation of evidence that some things are clear and everybody should believe them, and there are some aspects that are up to consideration. You might consider doing this or that. And so that's the range of certainty also depending on what is available as scientific evidence. So I'm sure that there are few people, there are some people, but there are few physicians that would say, okay, even a 1A classification of evidence, I don't trust it, so I don't do it. I think that in that case, there is a role for governments to say, okay, if you do not follow the rules in any patients, then you're not able to treat those patients.
That's a very interesting point of view to just force them all to do it. I mean, I think that it's a very interesting one, right?
Yeah.
As this is monitoring of quality of care and, you know, assessing how good that is and making, I suppose, a judgment call on whether, you know, the clinician's doing the right thing or not for the whole patient population. So, I mean, I think you've brought up the whole concept of therapeutic inertia, and you've asked, I suppose, specifically about whether clinicians don't believe the guidance. I think that another thing, though, is that often, you know, that, what is it, the Hippocratic Oath, that, you know, do no harm. I think that is a feature, but it shouldn't be for cholesterol lowering, should it?
So if I can, I should probably clarify, my question should perhaps be more rephrased, do they believe in the targets set in the guidelines? In other words, the targets are a moving number, and you just wonder, is it possible that in everyday practice, as a clinician, you form an opinion that maybe that target is too severe or whatever, and that's contributing something to the treatment?
All right, well, I mean, let's ask our experts about, you know, how low is too low when it comes to cholesterol?
There is no lower limit as far as we know. I remember when participating in the PCSK9 trials, you sometimes saw LDL levels that were unbelievably low, and I think it has been studied well that even at these extremely low levels, there are no negative influences. So I think the concept is the lower the better. That still stays. But I know that there are some difference in opinion. For example, in Belgium, the general practitioners have an organization, and in their guidelines, they do not use the ESC guidelines. They are always a few years after the ESC to change their guidelines. And so then it's difficult. As cardiologists, we say, this is the guideline, this is the target. And the GP says, yes, a little bit higher could be. And that's what you say. So there is discrepancy. I'm convinced that ESC guidelines are better than the Belgian general practitioner guidelines, but yeah, that's a whole other topic to work on.
Okay, let's not go there. Is there any other questions or comments from the audience?
At which age you justify the screening for patients which have no risk factor? I mean, 30, 40, I mean, or earlier?
That's a good.
Rahul, do you want to take that one?
You know what? If there's family history, right? You should, even if you're a child, right? But I think every adult should be aware of its own numbers, you know. So maybe 18. Yeah. I know. I'm in favor of pediatric screening overall for everyone. Okay, independently of, because you can have a hint of bad things very early. Okay, but let's say if you don't do that and there's no family history, but if you're a young adult, you should have an idea, you know. You know, one of the concepts that we have worked on the roadmap is the long-term exposure to inadequate LDL cholesterol levels. Even if LDL is not high, it's average, the longer time, the worse for you, right? So that's why we should implement ways of reducing cholesterol, not with medication, but let's say with adequate lifestyle, right? And that can make a lot of difference in the long term. And of course, if you find high cholesterol, you have to have a good, because we're discussing about lifetime risk also, right? Not only 10 years. So if you're young, but you have an LDL of 160, let's say. In the long term, probably your lifetime is more than 60%, right?
Did you want to add something there, Paul?
Yeah, so within the European Association of Preventive Cardiology, we developed the concept of prevention from cradle to grave. And really, and even before cradle, you know that the health of the future mother and father determines the cardiovascular risk of the baby, depending on well, smoking and obesity and all these kind of things. And I think in all stages of life, you have a different approach. I think in the future, we should do a heel prick and check for FH, for example. That's that's an easy shot, and you would have 99.9% coverage and everybody treated, and this large proportion would already be eliminated. Then, of course, there is the school age where you can educate people into healthy choice in nutrition, movement, and all that. I'm convinced that it would be best that in young adult age, for example, in Belgium you have occupational medicine. Everybody working in a company should go and see a doctor sometimes, and they check for business-related dangers, but there is no problem for this occupational physician to also check blood pressure and once check cholesterol. We do that in our hospital. We give the people, the nurses and the doctors working there, the opportunity that if they want, the hospital pays for a cholesterol check. And so once you know your cholesterol, okay, you go into the track of the normal healthcare, and then it's treated by the physician. So I think at each stage there is opportunity to screen and refer, and then of course it's up to the person if he wants to become a patient or not.
Neil, I'm just going to ask you one more question following these comments. I mean, who are the additional partners do you think we need to make here to be able to do all of what we've just described here?
Well, clearly to do, which I fully agree with, the idea of and obviously I'm not a clinician, but it's very obvious that it's the increased exposure to cholesterol over time, which we now know is the big issue. So I personally think the idea of cholesterol check at birth, and now outside of those with known history, at a population level, maybe another screen, I don't know, 20, 30, whatever you deem as the appropriate age, so that at least there's some investigation that we can move in and control. But for that to happen, you need government policy. And this is why I go back to the EACH initiative, for example, and the importance of having, I mean, at a national level, if you were to do a survey in the morning in the world and answer the question, how many countries have a national strategy on cardiovascular disease?
So maybe I can ask you a little bit more specifically. I mean, I think that we all understand that this policy changes are needed, but in a country, how do you start? Is it, you know, the local heart foundation going to, you know, knock the door of some politician, or is it the local heart foundation going to partner with somebody, or, you know, can you talk through some of those
I definitely
things?
think, and I'm using our own case in Ireland as a model, if you will. It was something we're trying. We don't have a national cardiovascular policy. We, as a civil society group, commissioned an independent national position paper on CVD prevention, and there are clear recommendations from the expert committee on that. Our next step is to bring together as many diverse community stakeholders. I mean, employers, for example, trade unions, civil society organizations, as well as the clinicians, because this impacts everybody. And to use that then to create a manifesto, basically, at a national level, to call on the decision makers to have policies and to put them in place. But it needs to be, going back to the our action plan, it needs to be an alliance of all relevant stakeholders.
Okay. All right, look, I'm going to round up in a sec. I'll take this comment once more, but I am going to ask you all to tell me what you're going to do in the next 12 months to make a difference. Did you want to respond?
I would just add to this and say that there are some good examples in Europe of countries that have developed this comprehensive national cardiovascular prevention program, and I think these can serve as examples, and I think ESC is trying to sort of write a manual how to approach it, because as you said, Neil, it is work that is not for cardiologists alone. It's patients, cardiologists, and the whole civil society.
It's got to be everyone's problem, right? Because it is everybody that is benefiting here. All right. Rahul, can you tell me, what do you think that you're going to do in the next 12 months here to make a difference?
I hope to do a lot of stuff, you know. First, to keep trying to educate my peers and bring them the best reliable information. And at the same time, do a lot of noise with my patients and actually to really try to influence on the politicians that work with health in Brazil. My country, we have more than 200 million people. So it's a lot of people.
That's a lot of people.
And definitely, we must increase awareness and we must bring these policies, you know, regarding cholesterol and prevention to the government. Because prevention is the word, in my opinion. And definitely we can make the difference if we really organize ourselves with the civil society and put everybody together. You know, and we don't need much. And I think we can save a lot also. That's how I see it, you know.
Fantastic.
Yeah.
Sounds like you'll be busy. Paul, what are you going to do in your next 12 months?
I would like to recall the prevention paradox of Jeffrey Rose, who said that you can have, let's say, a very large impact on the one person sitting in front of you. So I tend to do so. I always, when I have a patient in front of me, I'm aware that I should really go to the limit, to the optimal treatment. On the other hand, you can have a huge impact by policy measures, even by having a very small change. So if in 11 million Belgians you can lower the blood pressure by 5 millimeters of mercury, by, for example, reducing salt, then you can have a huge impact on more than my impact on this person in front of me. So I would like to continue doing both. The person in front of me, I will treat him as good as possible. In the university, I will try to make the doctors of tomorrow also as good as possible. But then at government level, I think we have now the momentum, and we are at this moment with the Belgian version of the EACH. We are working at showing politicians that this is something we have to do together. Patients, clinicians, politicians, and all the rest.
Fantastic. So treat the individual and then treat the population simultaneously. Yep. And I think there's a Jeffrey Rose presentation later today, the lecture. All right. Up to you, Neil. What are you going to do in your next 12 months?
Specifically on the cholesterol issue, I've mentioned that what's needed is an unprecedented advocacy initiative globally. You can't boil the ocean overnight. So using the civil society initiated cholesterol action plan, I'm hoping that we can pick 2-3 countries perhaps and try and partner with all the key stakeholders to see, can we create a strong alliance that starts to advocate for policies that will address as many of these issues as we've discussed.
Fantastic. All right, well, thank you very much, Neil, Paul and Rahul, for all of your work thus far, and also for sharing your thoughts today. I'm sure if people want to talk to our great speakers, you can. So enjoy the rest of your meeting.
Thank you.
Thank you.